Good evening, ladies and gentlemen. On behalf of my colleagues in the organizing committee of Dubai Pediatric Club, I would like to welcome all viewers from Dubai, UAE, GCC countries, and all countries across the globe to this webinar. This webinar is CME accredited in collaboration with NMC Specialty Hospital Dubai and is sponsored by Vita Biotics UAE. I would like to thank the country business manager of this company, Mr. Tawfiq Ali, who is always supporting us. Well, tonight's webinar topic, as you know, is pediatric and adolescent urology and urosurgery. We have eminent speakers, panelists, and moderators. In a short while, I'll be introducing them to you. As usual, we have a question. You have about 5 minutes to tell me who is this gentleman and why he is famous. You can write your answer in the chat box. Well, welcome to Dubai, one of the best cities, beautiful cities in the world. If you have not seen, please come and see. Members of Dubai Pediatric Club in the beginning and now, on behalf of all of them and on behalf of the organizing committee, I would like to welcome once again all the viewers. In the organizing committee, Dr. Rajinder Joshi, past president, Dr. Kalpana Sengupta, secretary, Dr. Diari Muhammad, chairman of the academic affairs, Dr. Amir Muhammad Tolema, Dr. Ayman Jundi, who is tonight as is our moderator, Dr. Rafia Overa, Dr. Srinivas Bandari, Dr. Leila Bari, and Dr. Khalid Rashid. Well, as I said, today we have eminent speakers and panelist moderator. Our speaker is Dr. Hilal, senior consultant pediatric surgeon at Tawam Hospital, Dubai, UAE, sorry, Al Ain, UAE. We have Dr. Debashi Sengupta, senior consultant pediatric urologist and andrologist at Tadawi Hospital and in Health Hub Clinics, Dubai. We have with us also Dr. Martin Bitzan, senior consultant pediatric nephrologist at Al Jalila Children's Hospital, Dubai, and Dr. Diari Muhammad, well known to all of you, senior consultant pediatric surgeon at Al Jalila Hospital, Dubai. We have two moderators, Dr. Kalpana Sengupta, head of Department of Pediatrics, senior specialist pediatrician and secretary of the club, and Dr. Ayman Jundi, consultant pediatric surgeon at Valiant Clinics and King's College Hospital. I've circulated the profile of all the speakers and all the viewers, they know details about our speakers. Well, next month on 22nd Sunday, we have a webinar on fluids and electrolytes therapy. We have eminent speaker from India, Professor Jayashri M, consultant pediatric intensivist at Advanced Pediatric Center, PGI, Chandigarh, India. We have also eminent panelists, Dr. Intisar Adhamadi, consultant pediatric nephrologist at Al Jalila Children's Hospital and Zulaikh Hospital, Dubai. Dr. Monica Ghoshal, well known to all of you, consultant pediatric neonatologist and director of Emirates Specialty Hospital, Dubai. And Dr. Deepika Gandhi, consultant pediatric intensivist at NMC Royal Hospital, Sharjah. Don't miss this webinar. Well, our annual conference, 8th annual physical conference will be on Sunday, Saturday and Sunday, 26th and 27th of November. Detail will be announced. As mentioned earlier, we are having a Dubai Pediatric Club YouTube channel. You just write DPC annual conferences, you will find all our webinars there. Well, our sponsor, Mr. Tawfiq Ali, who is always supporting us, he is seen here being stated by founder of Dubai Pediatric Club, Dr. Let Kuhi. Well, in next just 10 minutes, I'll give a brief history of pediatric urology, which is very interesting. Well, in ancient time, there was patient urine sample and urology wheel or urology chart, like Eurostick you are putting. They used to take the urine sample, compare it in the child, and give the diagnosis. Now, Isaac Newton said, if I have seen farther, it is by standing on the shoulder of giants. Although by standing on the shoulder of giants, you may see farther, but you may get rid of the over-distended bladder and its complication as well. Well, as I said, everything starts with Hippocrates, and always I start in the memory of Hippocrates. See, Hippocrates in 460 BC said, I will not cut even for the stone, but I will leave such procedure to practitioners of the craft, like Dr. Sengupta and others. This is from original Urology. Hippocrates reference is there, you can see. Hippocrates also said, if the urine be extravasated into the abdominal cavity, recovery is rare. See, 400 BC, these statements are given. Sushruta, father of pediatric surgery. William Ladd, father of pediatric surgery, who is well known by Ladd's band and Ladd's procedure. And it is interesting to know, this is Dennis Brown, the father of pediatric surgery in UK, who established a specialty in UK. He was an amateur tennis player and appeared 4 times in Wimbledon. He created several medical devices, including Dennis Brown bar and Dennis Brown crucifix. And he devised his own approach to the repair of hypospadias. And he was the first president of British Association of Pediatric Surgery. Well, we all have heard about Tellendelenburg position. He was the first reconstructive procedure of UP junction obstruction was performed by Tellendelenburg. Ligation of renal pelvis first introduced in 1986. It was modified by Kelly, just as I'm mentioning. Now answer to the question. Dr. Hugh Hampton Young, a pioneer in pediatric urology, please remember his name. Dr. Young was one of the most prodigious stalwarts in the history of urology. He established first urology residency program. He founded Journal of Urology in 1917. He performed radical perineal prostatectomy. I'll tell you about that. He described stages of posterior urethral valve 1 to 3. He performed bladder neck repair for extrophy epispadias. And he performed bilateral subtotal adenolectomy in congenital adrenal hyperplasia. See how great man he was. Now see, he's a student. He was chief of genital urinary surgery under William Halsted. Who is William Halsted? Father of surgery. He was working under him, and his students are Frank Hinman Senior, father of Frank Hinman Jr. I'll tell about it, and Foley, Frederick Foley, Foley catheter. Every day we are talking about Foley catheter. He's a Foley, a student of Young, Dr. Young. Now you see here how great was this Dr. Halsted, the first radical perineal prostatectomy for cancer of prostate was done at Johns Hopkins Hospital on April 7, 1904 by Dr. Young with assistance of his chief. See, the chief assisting his student. Rarely you see nowadays. Now, a very rare picture, you see 3 heads here. Dr. Halsted, the head of father of surgery. Dr. Young, father of urology, pediatric urology. And who is he? Dr. Harvey Cushing, father of neurosurgery. Cushing syndrome, we know. Now, this is a very interesting operation scene. 3 fathers, Halsted, Cushing, and Young, they're operating at Johns Hopkins Hospital. Very beautiful photo. Now, if a surgeon, if all surgeons are famous and the operation is unique, this will be the condition of operating theater. And in 1927, there was American Urology Association meeting. All of the delegates, they wanted to see the operation of Dr. Young. They saw, they were surprised, and there was a testimonial dinner in honor of Dr. Young. And he was felicitated. Look at the people and the dress code. I was really impressed with the dress code with papillon. Papillon is a French name for neck bow. This is Dr. Frank Hinman Sr., who trains so many urologists. And this is interesting. I would like to request you to pay attention here. Actually, in early 50s, there was one meeting of American Urology Society. These two gentlemen, while going expense, and Dr. Baker, I can't see the name fully down there, they were going by taxi to the airport. In the taxi, they discussed that why not to have a pediatric urology conference. They called all doctors, 8 attended the meeting. On first meeting was in 1951. It was at Hilton, Chicago. Who are there? Bicknell, this is Dr. Bicknell, Dr. Campbell. You know Campbell Urology book. And here, Frank Hinman Jr., who has written many books, including Atlas, and Dr. Spence. Now, I would like to ask a question. There is a condition associated with the name of this Dr. Hinman, a syndrome. 10-second time you have to answer. Yes, Hinman syndrome. Hinman syndrome is a neurogenic bladder. It is avoiding dysfunction of the bladder of neuropsychological origin that is characterized by functional bladder outlet obstruction in the absence of neurologic defect. We must remember them. And they are the two of the pioneers, Dr. King and Dr. Latimer. We must remember also they have done a lot for urology. Now, this gentleman, Dr. Everett Koop, who was a pioneer in pediatric surgery and U.S. general surgeon for many years. Here is being felicitated by U.S. President Ronald Reagan. He was one of the pioneers in the pediatric urology. How? He actually recruited Dr. Dockett. And Dr. Dockett was there for 26 years. He recruited this Dr. Schneider. Please see this last line. Dockett-Schneider collaboration was one of the richest source of academic accomplishment in the history of pediatric urology. And this is Dr. Cunning, the student of them who trained all these urologists, and this is in John Hopkins 2005 urologists. Since today you are talking about adenonephrosis and another thing, Dr. Michael Harrison is considered father of fetal surgery. He performed the first open fetal surgery in 1981 in vasectomy for congenital hydronephrosis. And this gentleman did the first, Schosler and his associate, laparoscopy pyeloplasty. It is interesting to know he did the first laparoscopic prostate operation in 1991 also. And they are the pioneer, D.I. Williams in England and Dr. Johnson, pioneers in the field of pediatric urology in England. Some of the pediatric urologists in England, remember the pioneers. Just, I want to show you in this one only here. Actually, this started from 1550 BC in Egypt. Hippocrate kidney affection described. Just see how the great. Now it's once again, beautiful painting showing patient urine chart. Well, I'm ending. I would like to just once again introduce our speaker, Dr. Hilal Mata, consultant and chief of the pediatric surgery department at Tawam Hospital, Al-Ain, UAE, Dr. Debashish Sengupta, consultant urologist and andrologist at Tawawi Hospital and Health Hub Clinics, Dubai, UAE, Dr. Martin Bitzan, consultant pediatric nephrologist at Kidney Center of Excellence, Al Jaila Children's Hospital, Dubai, and Dr. Diari Mohammed, consultant pediatric surgeon at Al Jaila Children's Hospital, Dubai. Well, I'm ending the quotation by Louis Pasteur. In the field of observation, chance favors only prepared mind. If mind is not prepared, even chance will not help you. And Hippocrates again said, first do no harm, especially for surgeons. My reference says, thank you very much. Once again, I would like to welcome to Dubai. This is Dubai at night. It is taken by daughter of one of our colleagues, pediatric colleagues. Thank you very much. Now I would like to request Dr. Hilal Mata to start his presentation, I would like to request all the viewers to write their questions. These will be discussed in the panel at the end of presentation. Over to you, Dr. Mata, please.
Good evening, everybody. Can you see the screen clearly?
Yes, doctor, please.
Okay. First, I would like to thank the Dubai Pediatric Club for inviting me to talk tonight. And I choose two topics, mainly because of their importance to the pediatrician. The first one is vesico-ureteric reflux. Pediatricians are the first line in treatment of UTI, and they are the one who initially will face this problem. The other one is about neonatal circumcision. So to save the time, I will start with vesico-ureteric reflux. I hope by the end of this short presentation, we know what is VUR, what type of VUR there is, what are the symptoms of VUR, what is complication, how we diagnose it, and what other tests we need to do with patients, with children with VUR, and how is primary VUR is treated. VUR, as you know, is a retrograde flow of urine from the bladder up the ureter to the kidney. And there's two types of VUR actually. There's the primary VUR, where this is the primary condition, and there's the secondary VUR. Secondary VUR is due to distal obstruction or to high pressure bladder. What our presentation tonight is exclusively on primary VUR, because secondary VUR that can happen in posterior ureter valve, in urogenic bladder, each of these topics are a topic by themselves. So we're focusing tonight on the primary VUR. What causes the primary VUR? The classical description of the etiology of primary VUR is that there's a deficiency or defective uretrovesical junction. The ureter enters the bladder at an oblique angle and enter the detrusor muscle at an oblique angle, and then it goes submucosal to a certain length and then open at the ureteric orifice. And it's thought that the submucosal tunnel that prevent reflux during the filling of the bladder because of the pressure of the urine, and during micturition, when the detrusor muscle contracts, that will close the ureter and prevent reflux during micturition. The real cause of why this happened is unknown, although there is a very strong familial component to this condition. There's no genetic genes that has been specifically identified, although VUR is very common among children and siblings of parents with VUR. And it's estimated to be 20–30% association between sibling or parents with VUR if they have children with VUR. In infancy, VUR is more common in boys. In older children, VUR is more commonly, frequently diagnosed in girls. I will talk later in quite a little bit more details about the role of bladder bowel dysfunction, BBD, as an etiological factor in vesico-ureteric reflux. VUR is quite common. Of all children, it's estimated that 1 to 3% of all children have some degree of vesico-ureteric reflux. But if we look at children with urinary tract infection, this is much higher. It's estimated that 30 to 45% of children with urinary tract infection have vesico-ureteric reflux, and this is more common in male than female. So male with UTI are more likely to have VUR than female with UTI. And also 15% of prenatally diagnosed hydronephrosis is caused by vesico-ureteric reflux. VUR by itself is asymptomatic, doesn't cause any symptom. The symptoms are due to urinary tract infection. The question is, how does VUR predispose to urinary tract infection? This will can demonstrate it very clearly. In the normal patients, bladder is full, there will be micturition, bladder empty, and post-micturition, bladder remains empty. In patient with reflux, bladder is full, there will be micturition, bladder empties, but some urine refluxes up the ureter, and post-micturition, that urine that refluxes up the ureter goes back down and into the bladder. What will happen is there will be post-void residual, there will be stasis of urine, and as we know, wherever in the body there is stasis, stasis equal infection. What kind of infection the VUR cause? Well, it can cause simple bacteriuria, asymptomatic bacteriuria. It causes cystitis, and it causes the most severe and serious pyelonephritis. As a side issue here about pyelonephritis, it's late in the 80s and early 90s in UK, in Great Ormond Street Hospital, Professor Philip Ransley, who's a famous pediatric urologist, he did a lot of work initially on animals and then on human, and he found that pyelonephritis happens more commonly with children with VUR who have a morphological abnormal renal papilla. And he demonstrated that the renal papilla is two types. The one is conical type, and the other ones is called compound type. Compound type is like two conical type fused together. This is like congenital, they are born like that. With the compound type, there is more likely to have an intrarenal reflux, and he coined the term intrarenal reflux. So you can imagine if the urine that has bacteria reaches up to the renal calyces and there is an intrarenal reflux, so this will predisposes more to a pyelonephritis. How we diagnose VUR? This is just, I took it from one major review, the number might change. It's estimated that in the first 7 years of life, 1.7% of boys and 7.8% of girls will have a UTI. Of course, it's much more common in girls because they have shorter urethra, and there's an ascending infection is commoner in girls than in boys. So when you see a patient with urinary tract infection, which one of them needs investigation for the possibility of having vesico-ureteric reflux, knowing that urinary tract infection is quite common in children, specifically in girls. It's been kind of for years and years well accepted that we need to investigate VUR in males after a single episode of febrile culture-proven urinary tract infection, and in females after 2 episodes of febrile culture-proven urinary tract infection, for the simple fact that female is more prone to UTI, is much common to have UTI. So we investigate for VUR if there's 2 febrile culture-proven infection in female, but in male being rarer to have UTI after 1 episode is enough. The reason of that is investigation for VUR, as I mentioned later, involved avoiding cystourethrogram, which is an invasive study, involved catheterization, discomfort to the patients, significant radiation exposure. So we don't need to do it on everybody who have VUR, or everybody who has a urinary tract infection. Okay, if there's a family history of VUR, as I mentioned earlier, there's strong familial tendencies for VUR. If the siblings has a VUR, parents has a VUR, and the child come with a proven culture-proven urinary tract infection, then we are justified to investigate fully for vesico-ureteric reflux. most children who have UTI, I'm sure the family physician or the pediatrician would have done an ultrasound scan to the kidney, ureter, and bladder. If on the ultrasound scan showed a dilatation of the ureter, then that is enough justification to investigate for vesico-ureteric reflux. Also, children with prenatally diagnosed hydronephrosis. Prenatally diagnosed hydronephrosis, we know whether it's caused due to the PUG obstruction, the commonest cause, or reflux. It's managed by follow-up with regular ultrasound, maybe urinalysis. But if any of these patients with prenatally diagnosed hydronephrosis is seen with a febrile, culture-proven urinary tract infection, we have to investigate vesico-ureteric reflux. The only diagnostic investigation for vesico-ureteric reflux is voiding cystourethrogram, VCUG, or micturating cystourethrogram, MCUG. It's very accurate. It has very high sensitivity and very high specificity. And I put here, if it's done correctly. Why I say that? Because to be done correctly, the bladder has to be full to capacity. What I mean full to capacity, because we need a voiding phase. It's called voiding cystourethrogram. If you cystourethrogram, there's no voiding phase, that's a useless cystourethrogram. A great number of the radiologists in my hospital, they dislike me because I keep coming back to them complaining about ineffective, not properly done, useless voiding cystourethrogram when the report comes back that they filled the bladder with 40 mils of contrast, there was no reflux, and they removed the catheter, and then they waited 20 minutes and the patient didn't void. This is totally useless VCUG because first the bladder wasn't filled to capacity. And if the bladder filled to capacity, the patient will void, not just the patient, anybody will void when the bladder is up to capacity. So actually in our radiology room, I put a sticker on the wall with bladder capacity. What's the bladder capacity? So our radiologists will know how much to fill the bladder when they do voiding cystourethrogram. There's many formulas, age times 2 times 30, age plus 2 times 30, age times 30 plus 30. A simple formula is simple weight times 7. If you put the weight times 7 equals bladder capacity in mils. So the bladder has to be filled to capacity so you can get a voiding phase, because VUR can only be present during the voiding phase. And a VUR that doesn't have a voiding phase, it's not an acceptable VUR, and it's not diagnostic for vesico-ureteric reflux. If it's done properly, VUR, then you'll get the classical grading of vesico-ureteric reflux, which has been since 1985. It's grade from 1 to 5. 1, there's reflux but doesn't reach the kidney. 2, it reaches the kidney but the calyces are sharp. 3, there's little bit of dilatation of the ureters. 4 is blunting of calyces, indicating high pressure in the calyces and the pelvis. And 5, the most severe case, is when there's a huge dilatation and tortuosity of the ureter. Grade 1 or 2 are classed as low grade. Grade 4 and 5 are classed of high grade reflux, and grade 3 is classed as intermediate grade reflux. How do you manage VUR? The main aim of management for VUR is to prevent pyelonephritis, because if there's pyelonephritis, there'll be healing with scar tissue, and there'll be renal scarring, which means there'll be loss of nephrons, a condition which is called reflux uropathy, and eventually will lead to hypertension and end-stage renal disease. The management depends very much on the age of the patients, the grade of the reflux, the frequency of the urinary tract infections, and the renal, whether there's renal scarring and the renal function. As far as age is concerned, we know for sure that the younger the patients, the most likely that the vesico-ureteric reflux will resolve. So in the first several years, up to 5 years, it's very likely VUR will resolve due to the elongation of the submucosal tunnel, bladder and urethral growth, change of bladder dynamics, larger capacity bladder, and reduction in intravesical pressure. So it's been estimated that grade 1 and 2, there's an 80 to 85% resolution at 5 years. Intermediate grade is maybe 50% resolution. High grade, the resolution, spontaneous resolution is much lower. It's actually the intermediate grade 3 and 4 where most controversy as far as management is concerned. And as I said, the aim of the management is to prevent urinary tract infection, prevent renal scarring, prevent reflux nephropathy, which eventually lead to hypertension, chronic renal insufficiency, and end-stage renal disease. What are the management options that we have in vesico-ureteric reflux? We can just observe the patients. We can give them prophylactic antibiotic and there's surgical management of VUR. I'll talk about each individually. The principle of management, really the initial management that's recommended for prepubertal children with grade 1, 2, and 3, and possibly grade 4 is medical. And medical management, I'll talk about it in a minute, which means either follow-up or prophylactic antibiotics. Grade 5, which is a huge amount of reflux, is unlikely to resolve, and usually surgery is recommended after infancy, after 1 year of age. I mentioned here that we have to be a little bit more aggressive in the management for bilateral vesico-ureteric reflux. The reason is, in the unilateral vesico-ureteric reflux, only one kidney is affected. Even if there's scars in one kidney, if there's reduction in function in one kidney, the other kidney will be normal and the patient will unlikely to have end-stage renal failure. But when you have bilateral vesico-ureteric reflux, both kidneys are threatened. There'll be scarring in both kidneys, and is more likely to have an end-stage renal failure. Additionally, when there's a bilateral VUR and bilateral renal scarring, it's very difficult to assess renal function on the DMSA renal isotope scan, because DMSA depends on differential function. It depends on comparing a normal kidney with a damaged kidney. If both kidneys are equally damaged, the result of the DMSA will be 50-50, and it doesn't mean this is normal. That means they are equally damaged. So with bilateral vesico-ureteric reflux, bilateral renal scarring, we tend to be more aggressive in the management. That's very important, is to investigate and include causes of secondary VUR and BBD, which is the bladder bowel dysfunction. That's very important. In the past 15-20 years, that has taken a very important role in the management of vesico-ureteric reflux. And also we patients with VUR, knowing that there's a strong familial tendency, we have to be more careful if any of their siblings have a urinary tract infection, so they should be screened for VUR. As far as medical management, it's been well established over the past 30 years through a large, huge, multi-center meta-analysis studies that shows that patients receiving prophylactic antibiotics has reduction of UTI recurrence compared to placebo. The reduction is between 30-40%. Prophylactic antibiotic doesn't abolish the urinary tract infection. It does reduce it, but it's definitely statistically higher than placebo. Also, these huge studies show there's no clear evidence for children with low and intermittent grade reflux, which is 1, 2, 3, who are asymptomatic, no history of a febrile illness, and therefore just observation might be justified. Additionally, these studies have showed there's no statistical, and that's important, no statistical difference in long-term new renal scarring between medical and surgical management in grade 1, 2, and 3 vesico-ureteric reflux. So there's no doubt patients, when they first come with UTI, first infection or second infection, and you diagnose vesico-ureteric reflux, and especially if it's grade 1, 2, or 3, the initial management is medical, and the recommended prophylactic antibiotics. You can use trimethoprim or nitrofurantoin. I personally start with trimethoprim unless the patient is under 3 months of age, then amoxicillin is recommended. The dose is 1.5 milligram per kilo once a day. I will change to nitrofurantoin if the patient, while on trimethoprim, get cystitis or UTI that are resistant to nitrofurantoin. I'd like to talk a little bit here about a very important topic, which is the bladder bowel dysfunction, BBD. What is BBD? This describes a spectrum of lower urinary tract symptom loss that is accompanied with fecal elimination issue. The lower urinary tract symptoms that are common to BBD is usually include dysuria, urgency, urinary frequency, hesitancy, daytime incontinence, enuresis, dribbling, straining, voiding postponement, urinary retention. Some conditions like overactive bladder, underactive bladder, and dysfunctional voider can be part of BBD. And as far as the bowel is concerned, BBD manifests itself in constipation and encopresis. And we all know for ages that constipation is a factor in the urinary tract infection. What's causes BBD is unknown. It's probably functional, neurological. It tends to be associated with AD, attention deficit disorder, and autism spectrum. They have patients with BBD that don't have UTI, but they have patients with BBD who have UTI but don't have reflux. We have patients with VUR that don't have BBD, but the incidence of bladder bowel dysfunction in patients with VUR is quite high. It depends on which reference you look at, the range between 30 to 60% of children with VUR. It's a quite high number, and that's why it led some people to say there must be a causative effect or causative association, etiological association between VUR and BBD. To the point that the American Urological Association in 2010 has stated that BBD, which is very common in patients with VUR, it stated that it increased the risk of breakthrough infection in children on prophylactic antibiotics. It reduced the success rate of endoscopic injection therapy for VUR. It increased the risk of post-operative UTI, and they recommend that physicians are strongly recommended to investigate and treat BBD in patients with VUR. Assessment and treatment of BBD, they reckon that it's imperative in the medical and surgical management of children with VUR. It is one of the causes that now, as surgeons, we feel it's one of the main causes of failure of surgical treatment for VUR. How do you manage it? First, you have to assess that the patient has BBD. As far as bowel is concerned, he has constipation, 2 or 3 less defecation per week, with stool incontinence or house stool movement or lost fecal mass in the spectrum. I mentioned earlier about what are the urinary frequency of urinary symptoms of BBD. Evaluation with physical examination, bladder diary. You can do plain X-ray of the abdomen to look for fecal loading, also to look for possibly if there's any abnormality in the sacrolumbar spine indicating a possible occulta, spina bifida occulta. Ultrasound scan is important to measure bladder capacity and post-voiding residual volume. In certain patients, not all patients, I won't advocate all patients to have urodynamic VCUG and spinal MRI in the management of BBD. The treatment of BBD, most patients can be managed with simple measures, doesn't have to have any pharmacological management. All it needs is some behavior modification like time voiding, biofeedback, bladder diary, dietary intervention for constipation, oral laxative, and enema. In certain cases, we have to use antimuscarinic like ditropan or alpha blocker like tamsulosin. It depends on what we like to aim our pharmacology, whether we have it at the detrusor muscle, we use antimuscarinic, or we want to aim it at the sphincter, we use alpha blockers. When this surgery is indicated in BBD, in vesico-ureteric reflux, well, the indication for surgery if there's high-grade reflux. We know that grade 5 reflux will not recover, will not resolve, and in patient over 1 year of age with high-grade reflux should be referred for surgery. Low probability of spontaneous resolution. What do I mean by that? Older children, if the child reach near puberty or pre-pubertal, still have reflux, this child is unlikely to resolve. Patient with renal scarring already has recurrent pyelonephritis, have renal scarring, has breakthrough febrile UTI while on continuous antibiotic prophylactics, they should be referred for surgery. Occasionally, patients who you cannot follow, you cannot have a clear follow-up with regular ultrasound, regular urinalysis, you might be justified to do a surgical treatment as a definitive management of vesico-ureteric reflux. What type of surgery we have? There's two types only. One is minimally invasive with a submucosal injection of deflux, which is done through the cystoscope. And the other one is a ReImplantation to re-establish the ureteric submucosal tunnel. The advantage of the submucosal injection is very minimally invasive. It's done as a day case. It can be done again, it can be repeated, and it doesn't stop us from doing a reimplantation later. This advantage is not as effective as reimplantation in abolishing VUR. Reimplantation can be done as an open, laparoscopic, or robotic. And this is just two little diagrams about reimplantation. Basically, we recreate the submucosal tunnel. The success rate is similar for extravesical or intravesical reimplantation. It's a very high success rate for treating vesico-ureteric reflux. And it is the gold standard for treating vesico-ureteric reflux. I say it is the gold standard, but it's not the first choice. Our first choice currently is deflux injection. If it fails, even after second injection, then we go for ureteric reimplantation. Thank you. That's for vesico-ureteric reflux. I have maybe 5 minutes to go very briefly about the second presentation, which is about neonatal circumcision. I chose this because neonatal circumcision is very common. It's not done, it's usually done not by pediatric surgeon, many of them done by pediatric surgeon, but it's done by many other physicians, pediatrician, obstetrician, urologist, general surgeon. In other countries, done by non-physician as well. And it's estimated that about 30% of men globally are circumcised. So this is the commonest surgical procedure that's performed. And it's usually neonatal circumcision is performed under local anesthesia. The American Academy of Pediatric recommendation to do it under local anesthesia up to 1 month of age, but our practice is we go up to 4 or 5 months to do it under local anesthesia. Above that age, we do circumcision under general anesthesia. We cannot stick to the AAP because we'll be overwhelmed our OR if we have to stick to 1 month of age. The three main methods for neonatal circumcision, the most common one is the middle one, the Plastibell, and there's the Gomco clamp and the Mugan clamp, which is usually commonly used in the Jewish population. What I like to mention here is contraindication, when not to do neonatal circumcision. The reason is a lot of the complication we see is because circumcision is done when it should not be done. We all know, probably you all know, that a patient with hypospadias or penile cord, they should not have circumcision because we require this extra skin for reconstruction in the hypospadias. Penile torsion will require correction of torsion. Webbed penis is the same. Buried penis, that's very important. I started here because this is one of the conditions that we see a lot of complication. Patient who had circumcision and they had a buried penis and they shouldn't have had circumcision. Other conditions like urethral hypoplasia, epispadias, of course, there's ambiguous genitalia, and there's multiple of medical conditions that shouldn't have a circumcision, like bleeding, diastasis, skin or connective tissue disorder that interfere with the healing. Complications of neonatal circumcision can be divided into two parts: procedural during the operation and post-procedure. The overall complication reported, there's loads of literature about it. You can look at it. It varies between 1%, 1.5% to 15%. The procedural complications, some of them are related to local anesthesia. There have been case report of penile block causing penile necrosis, although it's extremely rare. Meatal tear can happen while stretching the foreskin. The forceps can go into the meatus and cause the tear. Penile shaft hematoma can happen if the inner layer of the foreskin doesn't get caught in the ring. There's sometimes immediate bleeding, which should be treated with abolishing the procedure and using suturing. Sometimes twisting of the device while circumcision can cause iatrogenic torsion, and we've seen cases of severe penile necrosis due to use of monopolar coagulation. Post-procedure complication, I mentioned a few of them here. These two are very common: foreskin adhesions and redundant foreskin. Many parents come to our clinic complaining that this circumcision is not right because there's adhesions or there's too much skin left over. This is purely a technical issue. Adhesion should be completely freed at the time of circumcision, and it's a technical issue to take enough foreskin, not too much, not too little. Bleeding is very common as a complication of circumcision. Most bleeding are minor, it's self-limiting, doesn't cause any problem. Sometimes can be very serious. So I've seen patients with post-circumcision bleeding with hemoglobin of 3. And I don't know if many of you know that many years ago, there had been a mortality in the UAE of a child who bled from circumcision. What do we do about it? A very important instruction we give to the parents. We tell them if there's blood on the nappy, anything bigger than the size of a dirham, they should bring the patient back to the emergency room. The other complication is circumcision when it's done on a buried penis. The buried penis is the penis is hidden in a big fat pad, and whatever skin above is just skin. The penis is completely hidden, and if circumcision is done, that skin is removed, and what happened, there will be healing of the scar over the penis on the abdominal wall, and there will be cicatrice. sometimes can be very severe and it causes a trapped penis. The penis gets trapped inside, and we will need some extensive surgery later on. Meatal stenosis is another complication of circumcision. And another very important complication that happens specifically with the plastibell device is incarceration of the plastibell ring. The plastibell ring, if it's too big, it slips down the penis and it incarcerates the penis. And this photo you see, this ring will not fall by itself. Patient comes to us, we'll have to cut it to remove it. And this is what we'll see once it's cut. And occasionally this will result in a fistula. And in the worst case scenario, you'll see something like this, a necrosis of the glands. Other complications are unsatisfactory cosmetic result. Many parents complain that one side is more skin than the other, it's twisted to the right, twisted to the left. These are not healthcare issue, but it's concerning of the parents. Penile cordy can happen if there's more ventral skin is taken, inclusion cyst, if there is smegma that's left without being removed. Iatrogenic urethral fistula can happen. Many cases have been reported of sepsis, including severe sepsis and gangrene in the penis, scrotum, and surrounding area. And some cases been reported of amputation and necrosis of the glands. Most complications in neonatal circumcision are preventable, and how we prevent them is by adherence to the contraindication. Experience and technique are important. Most important is clear post-operative instruction to parents. We give them a printed instruction sheets to all parents after neonatal circumcision and ask them to come without hesitation to the ER if there's any concern. Thank you very much.
Thank you, Dr. Hilal, for this wonderful lecture and clarifying a lot of issues for pediatricians. It's my pleasure now to invite Dr. Debashish Sengupta, who will be presenting his talk on transitional urology. This will be followed by the question answer session. So we will have the discussion after that. Over to Dr. Debashish Sengupta.
Okay, good evening, everybody. The topic I have been given today is transitional urology. Now, transitional urology is coming up in the field of urology because the adolescents are a special group of people having their own requirements. And it is different from adult urology and definitely different from pediatric urology. And transitional urology is a process that allows an adolescent or a young adult with a congenital or acquired urogenital anomaly to assume increasing responsibility for their own health care and become the primary decision maker in their care. This is the major difference I feel. Up till now, the parents were making the decision for them. The parents knew all about the condition the children had. The pediatricians were talking to the parents. Now, these children have going to become responsible adults. They have started taking responsibility for their own future. And definitely they should be taught what about all the illnesses they had so that they can communicate the same to their adult urologist. Now, of course, transitional urology is a huge topic. I don't think we can finish all the problems in one seminar. Each of these topics in fact require a seminar by itself. So what I've decided, I've taken some common problems which we see in our adolescent life, which we see in our adult practice. And I will like to highlight a certain points in them, not the entire thing, certain points in each of these topics. And what we should remember, what are different from either a pediatric practice or an adolescent practice. Let's take the first example of renal calculi. Now, renal calculi is becoming an increasing problem and in among children. The incidence of renal calculi is increasing world over from statistics taken anywhere. The first problem comes, in fact, in the diagnostic problems. Classically, we adults have always presented, we talk about renal calculi as having presented with loin to groin pain, classical renal colic with severe vomiting, nausea, and maybe dysuria. However, children do not present so often with this classical renal colic. Vague abdominal pain, hematuria, it might even be painless hematuria, and urinary tract infections are more common than classic colicky flank pain. The next comes in the diagnosis. When you get a patient with this suspecting renal stone, in adult urology, traditionally, we have done a CT scan. Why? Because some stones are seen on X-ray KUB. They are radio opaque stones, and some are not seen, radiolucent stone like uric acid stones. Ultrasonography is good for kidney stones. However, ureteric stones, the ones which present with classical colicky pain, are not very well seen on ultrasound. That's because probably to gas and other factors, and they don't have a window around them, the classical window of water around them. Hence, CT scan standard has been the gold standard for us for diagnosis of ureteric calculi. There we come to our first problem with children, because children are 3 to 10 times more radiosensitive than adults to radiation. We have got over this by developing low-dose CT techniques for use in children and also doing some limited plate CT in the area of interest, thus reducing the ionizing radiation to 50 to 80%. Now, as I've said, in another problem in the difference in adolescent practice would be that in pediatric cases of calculus disease, large number have a metabolic factor involved in the cause of these stones. In 1/3 of pediatric and adolescent patients also have anatomical abnormalities of the genitourinary tract. In contrast to this, hardly any adult patients you will get which will have some underlying metabolic abnormality. The metabolic abnormalities common in children and adolescents are basically hypernatriuria in 65%, hyperuricosuria, these being the most common metabolic abnormalities. Hypocitrate and hypomagnesiuria are the other common findings. Remember, citrate and magnesium are the inhibitory stone to stone formation, whereas uric acid, calcium oxalates are stone forming agents. Again, cystine stones also form a very large incidence of stone formation is there in children and adolescents, but in adults, we don't usually see cystine stones so commonly. Secondly, lastly, there has been a new interest in the incidence of bacteria in the formation of stone disease. And some studies have found that colonization of Oxalobacter formigens, the probacter, there is a deficiency of this probacter, and that is associated with a higher incidence of urolithiasis. Now, when you do the ultrasound, look at this ultrasound. This is what the classical picture in an ultrasound you see of a stone. This is a hyperechoic area, and there are many other hyperechoic areas here. But the classical sign we see for stone is that there is a post-acoustic shadowing, as you see in here. So when you see this ultrasound, you'll say, okay, it's a stone in an adolescent at the uretrovesical junction. You do the CT scan, and there you see the classical stone at the uretrovesical junction. Now, here lies one pitfall in adolescent patients. If you have not asked the previous history, we have seen that, look at the X-ray, what we have done. Now, what you see as a stone is a very well-defined area. This is not classical of stone. It has a very defined borders, and it is little oval in shape. Now, this patient has undergone a deflux surgery for vesicoureteral reflux in childhood, and up to 30 to 40%, 36% cases of deflux injection undergo calcification, and when they're seen later on in adults and can be misinterpreted as stones. So this is another pitfall in adolescent practice I wanted to highlight. Now, what are the treatment modalities for stone? Do they differ in children and adults? Not really. These are the common treatment modalities for stones that we have. If it's in the kidney and it's large in size, we can do ESWL, that is extracorporeal shock wave lithotripsy, or PCNL. The criteria for ESWL that it should be, for successful ESWL, I mean, it should be radio opaque stones. Because when we do a successful ESWL, getting up to 96% success rate, we try to localize the stones by both X-ray and ultrasonography. The other advantage of having double localization is the radiation due to X-ray is drastically minimized if during the entire procedure we monitor the stone that it is under the focus by ultrasonography. So when the stones are up to 20 millimeters or 2 centimeters and radio opaque, very good treatment with ESWL. Otherwise, we could do PCNL or even RIRS. RIRS is nothing but flexible ureteroscopy where we pass the scope right up to the kidney and break the stones. But RIRS, usually we cannot do much more than 2 centimeter stones also. Larger than 2 centimeter stones, usually PCNL is a treatment of choice. Ureteric stones, upper ureter, ESWL can be done if radio opaque, because here ultrasound localization of stones in the ureter is very, very, very poor. So we would like to have it localized by X-ray. If it's not radio opaque, or it is in the lower third of the ureter, we can obviously do a ureterorhinoscopy. And now I've told you about this ESWL, RIRS, PCNL. Just to give you an idea what we do mean by these procedures, here's a short video.
The surgical options are extracorporeal shockwave lithotripsy, ureteroscopy, or percutaneous nephrolithotripsy. Shock, where we direct high-intensity shock waves which are focused onto the stone, resulting in breaking the stone into small pieces which then pass out through the ureter. The procedure, we pass a small fiber optical instrument into the ureter and through it into the kidney, and under vision we break the stone with laser. These stones are broken into multiple small fragments. The larger fragments can be extracted along with a basket, and the smaller fragments usually pass out through the ureter. Even larger scope is passed, through which we enter into the kidney and break the stone again with laser energy. The advantage of this treatment is that even if the stone is large, it can be broken up into multiple smaller fragments, and most of the stone fragments can be extracted through the larger nephroscope sheath, resulting in greater stone-free clearance rates. However, this is definitely an invasive procedure.
Fair enough. So basically, you realize that PCNL is a highly invasive procedure. It's not a very simple procedure to do because it can result in bleeding in large number of cases. That's one of the complications. And ESWL is the safest procedure, of course. But the problem occurs in ESWL is trying to predict which stones will break on ESWL. Now, for a long time, we had the criteria that the composition of the stone determines our ESWL success. But then again, this is very difficult to obtain in adults, especially because that means that we should have a prior stone which he has passed and we have analyzed, or he has some metabolic abnormalities, so that we can guess what the type of stone would be having and thus predict whether ESWL will succeed or not. Recently, we have realized that the CT scan Hounsfield units, that is attenuation value of the stone, which the radiologist will give us whenever we do a CT scan, that is the best indicator for predicting ESWL success. But here also, there's a difference between children, adolescent, and adults. In adults, we have found out that if the attenuation value of the stone is above 970 Hounsfield units, the chance of success with ESWL reduces markedly. In children, this value is 600 Hounsfield units, and also greater than 12 millimeter stone length, usually the success rate is low. Like you see here that if the Hounsfield units are less than 600 Hounsfield units, there's an 82% success rate versus only 20% for patients with stones of greater than 600 Hounsfield units. Now that's about stone. The other common problem that we face in adults, we get adults with adolescents with varicocele. What to do about them? First, let me define what clinically we mean by varicocele. There are a large number of classifications for a varicocele. And clinically, we go about calling it grade 1 varicocele, which is palpable veins, but they are not visible. Grade 2 is they are palpable veins without valsavas, that is without any straining, and they are not visible. And grade 3 is both palpable and visible veins, even without valsavas maneuver. There's something called a subclinical varicocele, which is only detected on ultrasound. The ultrasound criteria for the simplest ultrasound criteria, there are again many criteria in ultrasound. Radiologists have their own, but we urologists take clinically the ultrasound criteria is that if 3 or more veins greater than 3 millimeter are seen with a Doppler flow reversal seen of blood, then we call it a varicocele. Now, this is what I mean by a grade 3 varicocele, a clinical picture, classically described as a bag of worms. This picture tells us the importance of examining a varicocele only in the standing position. This is a varicocele seen in the standing position. The same patient, if he lies down, the varicocele disappears, you can't see it. So varicocele diagnosis is made by examination in the standing procedure only. Of course, we have to confirm a diagnosis and we do it on ultrasound. And ultrasound, what we see is this classical cystic, anechoic cystic places. And when we measure it, it should be more than 3.3 millimeter in diameter, more than 3 millimeter in diameter, sorry. How do we know the cystic places, the cystic spaces are veins? We do a Doppler, and there it proves that these dilated cystic structures are nothing but vessels. And when we do a Valsava's maneuver, we see that not only is there reversal of flow, but the diameter of the vessels increase and they become more dilated. Now, what about the pediatric presentation of varicoceles? The highest presentation of varicocele we get in the adolescent age itself, 72% present, and most of them present with a grade 3 or a grade 2 varicocele. Now, one of the criteria we have used to realize whether we want to operate for a varicocele or not is to check the size difference of the testes. Normally, remember, there is always a 20% variation in size of the two testes. This is normal. But if there is a greater than 20% variation, that is the testes on the same side as a varicocele is smaller by more than 20%, then we know that the varicocele is affecting the growth of the testes. And this could be one of the indications for operating on them. Because obviously in adults, we are doing it, especially subclinical varicoceles. One of the criteria we're using is for fertility potential of the patient. But in adolescents, it's a very contentious issue to determine their fertility issue by asking them to do a semen sample, and that's out of the bounds of discussing in this presentation. So what we do, we see if the varicocele is affecting the growth of the testes or not. Now, when do we operate on the adolescent varicocele? As I've told you, if there's severe scrotal pain affecting the daily active lifestyle, or there is a difference in the scrotal size of greater than 20%. Here, I would like to bring one point in life, one point to mind for everybody. If in children we see that the testicular size is not growing, it is smaller, do we immediately operate? No. There are multiple studies, and especially one from this, which I've quoted, which shows that if there is a difference in testicular size in children, but you wait, by the time you reach adolescence, 54% or more, 85% or more will have achieved the normal testicular growth, and the difference in testicular size will not be something which is requiring a surgery. So in short, you do wait till they reach an adolescent life to see if the testes are going to have a catch-up growth or not. Now, once you're talking about pain in the testes, that is how the varicocele presents. The other one we want to talk about pain in the testes is the acute presentation of acute testicular pain. This is a child we're presenting with, these are two cases, different cases of acute testes. Now, the diagnosis obviously is torsion or epidermolysis. It's very, very important to distinguish between the two, because torsion of the testes requires immediate surgery within 6 hours of presentation if we want to preserve the testes, whereas epidermolysis is medical management with antibiotics. One of the ways we can distinguish clinically is what is known as the French sign, by lifting the testes up. And if the pain reduces or dramatically decreases, then mostly it is epidermolysis. Of course, you could try to feel the twist in the cord, but that is easier said than done. So the next test, most important we do, is a ultrasound, Doppler ultrasound. And this is classical of torsion testes, where you see this testes has no blood flow compared to the opposite testes. This is classical of torsion testes. Now, it's not that easy always doing the testicular diagnosis by ultrasound. Here, I would like to show you one case which we recently had. Now, you see the testes has, this testes has, you could say, more blood vessels, the supply is more, and this is normal. Now, this is classical of epidermolysis, where there is an increased blood flow in infection. Now, when we further did the ultrasound, you see this sign here, this twisted, enlarged area. This is classical, known as whirlpool sign in torsion testes. This is usually meant to indicate the twist in the cord. Now, look at this. This we were thinking in terms of classical of epidermolysis, increased blood flow, but we see the whirlpool sign in torsion testes. Now, here I want to bring one point in mind. What happens, supposing you don't even have an ultrasound, clinically you're not just sure, or in ultrasound also you're not very sure whether this is epidermolysis or torsion testes. The dictum states that in doubt, you must always operate. If you go down and find no torsion, there is no twist in the cord, and it's only epidermolysis, no harm lost. You just give a wash and come out, even the epidermolysis will settle. Now, when we do operate on a torsion testes, this is the findings we get, ranging from this being a normal pink testes, right all the way to a dark black testes, which is a dead testes, because this patient has waited for more than 24 hours after presentation for undergoing surgery. So we untwist the testes in the cord during the surgery, and we wait by putting hot mops on the testes, or some people even inject papaverine or vasodilators into the cord, and see if the blood supply is returning back. It may not come back to normal, but even if it comes back to like this light blue or dark blue, better than the initial presentation, in adolescent and children, we definitely give the testes a chance, and we do not remove the testes because they have great recuperative powers, and many of these testes come back to normal. Now, the commonest indication of testicular, the commonest presentation testicular in which age group is again in the adolescent age group. And children and adolescents presenting with testicular torsion for greater than 12 hours or more should still undergo surgical exploration, because the viability of the testes is difficult to predict. And I have seen in my practice also, many of these children and adolescents have wonderful recovery powers, and the testes are absolutely normal after some time. However, many of the children also in which we try to save the testes when we're not sure, and we have gone in for saving the testes, that over the long term, slowly the testes become smaller in size. That is, testicular atrophy develops post-operatively in 12 to 68% of the patients. And this again, we have seen is not related to how long later we have operated, but probably more to the degree of torsion at presentation that was there, rather than how the delayed presentation or the delayed time of surgery. Now, multiple studies have shown that school age and pubertal children have a decreased risk of testicular atrophy compared to preschool children. The other factor that you can use to help you decide whether this testes you should preserve or remove is if you have done the ultrasound previously, that is in patients who are presented for greater than 24 hours duration, and the sonologists tell you that there is a heterogeneous echogenicity of the testicular parenchyma, then that is a poor prognosis. But even if they have delayed presentation and they say that there is a homogeneous echogenicity of the testicular parenchyma, you should be more inclined to preserving this testes than removing it. Now we will do another, that's the end of the acute testes. Now I'll give you another case report to highlight another point in our practice. This is an 18-year-old male, presents with history of dribbling of urine and a poor stream associated with straining. There is also frequency, nocturia, and a sense of incomplete evacuation. He claimed to have avoided normally throughout childhood. No history of past history of urinary tract infections. On examination, of course, his neurological examination and spine were normal, his blood chemistries were normal, and urine studies showed nothing, no infection, nothing. Ultrasonography showed a grossly distended and thick-walled bladder with a high post-void residue. His X-ray KUB was normal, no stones, nothing was seen. Obviously, the next step, what would he do? We went ahead and did a cystourethrogram. And this is what we found, a thick-walled bladder. And this is it, dilated posterior urethra, classical of posterior urethral valve. So here I want to make the point that posterior urethral valve can present in later on in life, in adolescence, and even in adult life also. This was a type 1 posterior urethral valve. So these are the two leaflets, and we went ahead and incised it, and the final picture is completely open prostatic urethra. This is another 18-year-old male, just to prove my point and just to keep it in your mind that he had dribbling in childhood, which was cured by circumcision. And then everything was fine, and now he's presenting with narrow stream and incomplete voiding. And the ultrasound showed he had a significant post-void residual urine. We catheterized him, and large amount of urine was drained. And when we did the micturating cystourethrogram, again, we have what would be a posterior urethral valve. So don't think that posterior urethral valve does not present to us in adolescents, and even in adults, it is there. Lower urinary tract dysfunction. Now, even in posterior urethral valves, which have been treated in childhood, the lower urinary tract, that is bladder dysfunction, is a common finding in boys after posterior urethral valve ablation, regardless of the age at which they had undergone the surgery. 38 to 70% of neonatally diagnosed and treated posterior urethral valve present what is known as a valve bladder syndrome. And the bladder dysfunction seen in these patients, which persist even after posterior urethral valve ablation and can deteriorate over time, changed from an unstable hypercontractile bladder seen in infancy to hypocontractile in childhood, and finally to a true myogenic failure in adolescence. All these features were seen despite very early valve ablation. So the dictum is that posterior urethral valves, even if they've undergone a surgery, if they present to in adults, in adolescents and adults, they need to be still followed up to see if the bladder is going to deteriorate further, which will finally result in renal failure. Now, comparing the results of bladder dysfunction in boys with posterior urethral valves before and after puberty, as I've already told you, patients have a changing urodynamic pattern. Post-pubertal boys have very high capacity bladder with low contractility. This low contractility is a big problem because the bladder pressure end bladder pressure starts increasing, and it reaches above 30 centimeters of water on urodynamic studies. It starts leading to back pressure changes on the kidney. And that's what the prognostic factors for renal failure in such patients lie, that the bladder dysfunction can be considered as a prognostic factor in renal failure. Those with poor bladder compliance and myogenic failure have the worst outcomes. Whereas if it is only bladder instability or over-contractile detrusor, they are associated with less incidence of renal failure. Now, coming to the other type of neurogenic bladder, which we might present in our adolescent practice, is of spina bifida. These have been operated before, and now their bladder is unstable. Now, what are the type of neurogenic bladders we might get? It could be anything from hypercontractile bladder to finally, as I said, same thing as in posterior urethral valve, to an acontractile low compliant bladder. Now, obviously, our therapy is aimed at keeping the bladder pressures low. That is the one most important criteria. And the second line would be to try to get continence. They should not be wet always. So what is the type of treatment what we do? If it is an overcontractile bladder, we suppress it with pharmacological agents like anticholinergic, antimuscarinic agents. And we tell the patient to do a clean, self-intermittent catheterization. This actually, CSIC, is the real mainstay of all treatment of all neurogenic bladders. Anything, whatever the cause, CSIC prevents infection and renal failure. Now, this is the type of bladder we might get. As I was saying, it could be anything, but usually if it is above S2, we get what is known as an uninhibited bladder. At S2, S3, S4 level, we'll get an autonomous bladder because that's where the bladder center lies in the spinal level. And lower and below S3, S4, we might get either a motor atonic bladder or a sensory atonic bladder. Sensory atonic bladders are really the worst because patients never know when their bladder is full. They don't get any sensations. And there is high chance that the bladders become overfull and either it starts leaking or slowly there is back pressure changes start taking place, which are transmitted backwards to the kidneys. This is the same picture. As I said, above S2, S4, you'll get a motor spastic upper motor neuron type of bladder, and below S4, you'll get a flaccid bladder. Now, as I've already told you, treatment of bladder dysfunction, the uninhibited bladder, just to stress again, we'll give anticholinergic, antimuscarinic agents. In severe cases, when these are not helpful, we can even try botulinum toxin injection, which unfortunately has to be repeated every 6 to 9 months. We can also try detrocerectomy, but here, when we do detrocerectomy, we have to have an adequate bladder capacity. Small bladder capacities, you just can't do a detrocerectomy because the pressure still remain very high. And in such cases, bladder augmentation is done either by ileocystoplasty. In cases of atonic bladder, as I've already told, we just do CSIC, timed intervals, say every 8 hours they do it, 4 times a day and night is enough to keep the bladder at low pressures if they do clean self-intermittent catheterization. However, neurogenic bladders could have urinary incontinence. As I said before, one of the most primary, second after keeping the bladder pressures low, the second criteria is that they should be continent. Now, if the urinary incontinence is due to overactive bladder, I've already mentioned before, you can give them anticholinergic agents or botulinum toxin and then tell them to do CSIC. However, if the urinary incontinence is due to a paralyzed pelvic floor, we can do a sling suspension of the bladder neck. And this is important. In chronic neurogenic bladders, wheelchair-bound patients can manage the bladder better with a continent catheterizable stoma on top of the bladder. Now, especially in women, when I say about CSIC, actually practically, if you have ever advised any female patient CSIC, it's very difficult to teach a female patient clean self-intermittent catheterization because practically they just cannot, practical problem it is they cannot see the urethral opening. So we have to give them mirrors and all those sorts of things we have to do so that they can catheterize them themselves. But most of the time they require some help, and that is not the aim of our management. They should be self-sufficient. So this is the other criteria we can do. We can have an opening in the catheterizable stoma in the anterior abdominal wall. Now this stoma is prepared by joining the bladder, either a normal bladder or an augmented bladder, to the anterior abdominal wall by means of a loop of ileum, or it could be a appendix itself, like the Metrofinov procedure. And this is so easily, you can see they can catheterize the stoma and drain the bladder. Now, this is very important. These neurogenic bladders can deteriorate over time, as I've already mentioned. So they require yearly urodynamic studies and an ultrasonography for their follow-up. We have to make sure in urodynamic studies that their pressures, intravesical pressures, don't increase more than 30 centimeters of water. Finally, I think the time is nearly coming up to an end, but I will just mention one more problem we have in adolescents. The pediatric surgeons and all have repaired the hypospadias, but in many of these cases, there are 2 complications that can arise, which are commonly after hypospadias repair is a small fistula may remain, a distal fistula, I don't mean a proximal fistula, may remain. And parents have got tired of going for repeated surgeries to the doctor. And to them, the distal fistula really doesn't seem much of a cosmetic problem. The other problem is there is complications of hypospadias repair is that glans dehiscence. Just the glans dehiscence can occur, again leaving a subterminal external urinary meatus. Now, the aim of all hypospadias repair, we have to allow, why we require to repair hypospadias? Definitely to allow voiding in standing position. And finally, when they're adults, it requires you to allow the proper insemination of the sperm. And this is the problem which occurs in cases you have a subterminal meatus, that when they're adults and they want to have children, the subterminal meatus does not allow you to deposit the sperms into the vagina, and therefore they might present with infertility issues. The other problems also that come to us is, of course, in infertility. What I'm saying is about infertility, severe chordae, and I've already mentioned the subterminal meatus. This is the example of a severe chordae which will prevent the patient from having intercourse, and then again, we have to handle these problems. In previous times, when the repair of the hypospadias was done with a piece of skin, nowadays, of course, the gold standard is a buccal mucosal graft. It is now universally done nearly everywhere, but initially we used to do it with a skin patch. And when they come into adult life, then it can be problem with the hairy urethra. The hair growing in the skin can cause obstruction, infection, stone formation, and we have to think about handling these issues also. Lastly, I just want to mention to you pediatricians, which for us is becoming a bigger and bigger problem, is the sexuality in the spina bifida patients. This, I think, is still an understated problem. And this is very important because today we are trying to make them self-sufficient, not only self-sufficient, these adolescents, when they go into adult life, we are also trying to give them a good quality of life, and their sexuality and self-image consequently is very much dependent on having a good quality of life. 24% of adult patients with spina bifida were sexually active. And this is important. Almost all adolescents in this study with spina bifida had received a sexual education at school. Think of it. Not at home or least by their physicians. And we should have been taken, the pediatrician should have taken the first step when they were handing over these patients, or even when we received the patients, the adolescents, we should teach them about their sexual function and these things. Now, women were 2 to 3 times more likely to be sexually active than men. And this is just a study which came out. Women without hydrocephalus were significantly more satisfied than women with hydrocephalus. Participants with urine incontinence, that's the other thing. Now, not only have we to think of their ability to have intercourse and their sexuality. Now, one of the most important factors to maintain a good sexual function is having urinary continence. This is maintained in both men and women. You can't have a smell of urine around them, otherwise if they're incontinent. Now, also in women with bladder extrophy, epispadias complex, there were cosmetic concerns regarding the genital appearance. These also have to be addressed in this adolescent and early adult phase. Now, some of the surgeries we can do, like in males where the penis sensitivity is absent, we can anastomose the ilioinguinal nerve to the dorsal nerve of the penis. It's just an example I'm giving you how we can help them, other than, of course, doing a reconstructive surgery on the genitalia. So in conclusions, the pediatric patients with chronic urological conditions frequently require lifelong evaluation and treatment. Now, transition to the adult urological care is critically important, and goals of care shift to include sexual function, fertility, and genital reconstruction. Urologic goals include attention to the preservation of renal function and optimization of bladder function. Additional concerns, of course, which were not touched up in this topic in this presentation, is the long-term surgical complications, and we have to monitor for malignancy, especially after augmentation cystoplasty we have done. Well, thank you. That was the end of my presentation.
Thank you very much, Dr. Debashish, for this excellent presentation. Also for Dr. Mehta. Now I would like to request both speakers to join us. I would like to request our panelists, Dr. Diari and Dr. Martin, to join us. I would like to request Dr. Kalpana and Dr. Ayman to take over and start the panel. Thank you very much.
Thank you, Dr. Sohrab. We've got a lot of questions. We decided that we will start with the first thing first with Dr. Hilal, who has very nicely told us all about VUR. But certain questions that we would like to start about with VUR is that, Dr. Hilal, if we get a case of first febrile UTI, how far should we go to investigate? Should every child with first febrile UTI be investigated with the VCUG, and should we try to rule out VUR?
No, not every child with first febrile UTI needs full investigation, including VCUG, specifically if it was a female. So a female with first febrile UTI, we can just do, of course, urinalysis, ultrasound scan. If the ultrasound scan is normal, and especially if the urinalysis showed a multi-sensitive, not a serious bacteria, like not ESBL, or and if there is no family history of urinary tract infection, then you can just treat the patient with normal antibiotics, simple antibiotics, and then follow up. And it doesn't need VCUG. VCUG is quite invasive. It involves a lot of radiation, especially for a young girl, pelvis. We would not like to do it unless it's really absolutely necessary. In a boy, it's slightly different. In a boy, if it's a febrile UTI, especially if it's associated with pain, loin pain, and we suspect he might have a pyelonephritis, then we are more inclined to investigate the child if it's a male. So in these cases, we probably are justified to do VCUG in the male to exclude vesico-ureteric reflux. We shouldn't forget also looking for BBD, bladder bowel dysfunction, in both male and female, because this is a significant factor in urinary tract infection in people with VUR.
Thank you, Doctor. Dr. Diyari, I would like to ask you about siblings of children who are diagnosed to have VUR. Like Dr. Hilal mentioned during his talk, about 30% of them can also have VUR. So is an ultrasound enough as a screening procedure for these children, for the siblings?
Thank you, Dr. Hilal, and for this nice presentation on vesico-ureteric reflux. Yeah, as Dr. Hilal mentioned, that there is almost about 30 to 40% of siblings having vesico-ureteric reflux, especially if the parents are also affected and their siblings. So ultrasound, if the patient is just, you are going for screening, so probably ultrasound will be enough. If there is no hydronephrosis or hydroureter, then you will not do anything else. But if there is a symptomatic UTI, urinary tract infection, then probably you need to do MCUG, yes. And it has been found that in females, if a female affected, their sisters are more likely to be affected. But if a boy, the boy will be more having a high-grade reflux than the girl. So if you are doing that for the sibling is a boy, so it's having more higher grade of reflux than the female. Yeah, so we are not routinely doing it, but if there is any urinary tract infection, then for sure. And it's been not everyone you have to do. Mainly, there was Dr. Hilal may be aware of the Dublin family study, which has been done by Professor Primpuri. And he recommends below 3 years, not after 3 years to be done if you are doing any screen. So in order to pick it up earlier. Yeah.
Another question related to VCUG. When Dr. Hilal mentioned that the procedure, how we do it is very important, voiding phase is very important. So are there cases where we see reflux in the filling phase, but not in the voiding phase? Are they important? When does that happen? So Dr. Hilal, maybe you could enlighten us on this.
Yes, reflux can happen in both, in filling phase and voiding phase. When you see a reflux in filling phase, Still, if you don't do a voiding phase, it's not a complete investigation, because in the filling phase, you might see grade 1 reflux, only a little bit of reflux, but during the voiding phase, that grade 1 reflux that was shown on the filling phase, it becomes grade 3 reflux. So it's absolutely critical to have a voiding phase for VCUG, and anybody should not accept a VCUG without a voiding phase.
Right. So the grading will be done on the voiding phase.
Absolutely. We actually currently when we request VCUG, we put a note for radiologists, please call member of pediatric surgery to attend the VCUG, because we don't want to subject the child for a catheterization, all the discomfort, all the radiation for a useless investigation. So we are usually there present when they do VCUG to make sure it's done properly and it's diagnostic and it's not waste of time and suffering, unnecessary suffering for the child.
Dr. Hilal, you do one cycle or double cycle?
We do one cycle. Yes, so we fill out the bladder. If it's done properly, we actually also like to warm the contrast to 37 degrees. We fill the bladder to full capacity according to age or weight. And we do the filling phase and then remove the catheter. And if the bladder is really full, completely to full capacity, the child will void. And we don't accept any report that says the child did not void, so that's it, finished.
And lateral film of the urethra.
Of course, we do lateral. I mean, lateral is very critical if you want to diagnose the posterior urethral valve. Actually, it's called voiding cystourethropy. So we have to do a voiding phase and you have to do the urethropy phase. So a complete VCUG should include a voiding phase and should include picture of the ureter during voiding.
Right. So moving on from diagnosis to management, I would like to involve Dr. Martin. There is a question, in fact, a comment from Dr. Naeem, who has written about the role of prophylactic antibodies. He has said that the recent studies are controversial regarding the role of prophylactic antibodies, so antibiotics in VUR. So is there any criteria, any change in criteria? And he would like to know from the panelists whether personally, what do they think in their personal practice? Are you using it for all cases of VUR?
Okay, thank you. First of all, I would like to say that both talks were excellent and I really enjoyed the presentations. They were very clear. The question of antibiotic prophylaxis is certainly related to the overall concept of diagnosing VUR and how to see the fact of VUR in the overall prognosis of the patient. So the reverse study that was mentioned has indeed shown that, as we know, that there was a reduction of the number of infections, but that was coming at the price of having more resistant bacteria. And so we have already to ask us, and this is, as you know, the concept that has been changing recently, what do we really want to achieve? And I'm not talking about severe abnormality of the congenital abnormalities of the urinary tract and the kidneys, but the common variety of infection of the urinary tract and VUR. So VUR, as you said, is not a disease. So we're asking why do we really need to know that there's VUR, particularly if it's a mild or moderate degree? And why do we want to actually prevent infection? So one is clear, it's a nuisance, it is causing trips to the hospital and so forth and treatment. But on the other hand, the whole concept of reflex nephropathy is actually falling by the wayside, because those patients who develop end-stage renal disease have probably a congenital abnormality of the kidneys and of the urinary tract. So the VURs flag there's something wrong with the system and not the cause of the problem. And so now we're getting back and say, so what do we have to treat? And I usually negotiate with the parents. if they say, I'm really fed up with going to the hospital and treating, so we can try for a year or for 2 years to treat with a prophylactic antibiotic. But if they're not keen, and some parents do not want antibiotics, I will not push them at all. And then we can deal with 1 or 2 or 3 infections, and this is fine. Because what is the big concern? Scars. But are scars really a concern? So there are many studies now that show there are 2 kinds of scars. One is congenital scars, and the other one is post-infectious scars that we see more in girls, and the congenital are more in boys. So the post-infectious scars are probably completely innocent. So there's no increased rate of hypertension. There's no problems with pregnancy. They're actually just there. So whether we know they're there or not doesn't really matter. So we can actually save the radiation of the VCOG, and we can save the radiation of DMSA or MAC3 scan. So then, what else? Why do we need to know that? It's becoming less of a question. It's overrated in my view. So we're really dealing then with a few % of patients who have procedural valves, who have significant anomaly, and they need a comprehensive treatment. And we can actually be very relaxed about the mild to moderate reflux. So I don't know whether that answers the question, but if we think of it as a changing concept, we can pose the question of treatment and of prophylaxis in that new concept, rather than we have to prevent infection because they lead to end-stage renal disease. So that is a myth that we can really discard. Okay, I have spoken enough.
Yeah, well,
Yeah.
I have a question actually. Does the scarring happen although in reflux, although there is no history or documented urinary tract infection?
Yes, so that has been cited a lot, that there are scars that have nothing to do with infections. And there are scars that have been produced by inflammation, but it's probably half and half. And those who are born with scars, you cannot prevent them anyway.
May I add something? Now, when we are talking about scarring, we have 3 categories. Scar, which is, as just Dr. Martin mentioned, due to an inflammation, and this is due to an infected urine, which is refluxing. The other scan, which is a scarring, is a sterile scarring due to the high volume reflux, which is every time hitting the kidney parenchyma. The third one is the congenital scarring, which is the dysplasia, which has been occurred already congenitally. So when we are treating, we have to keep these 3 things in our mind. Now, Dr. Martin, it is not a disease. He mentioned the vasculoenteric reflux is not a disease, but now the new classification, they make it a disease and a symptom. So the disease is for those who are antenatally diagnosed, and they are having hydronephrosis with dysplastic kidneys, and they are mainly in males, and they will have a high-grade reflux. While the symptomatic is for the girls, usually, which they are in the 3-4, the toilet trained, let's say, age, which they are having the bladder dysfunction, little bit of dysfunctioning of the bowel and bladder dysfunction, and they usually have a low-grade reflux. And these are usually, they present with the symptoms. And these can be, even sometimes they don't need antibiotics or prophylaxis. Just by bowel management, they might get rid of it.
Yeah. What's the significance of differentiating the 3 categories of scarring on the management, in the management of reflux? What's the significance in distinguishing the 3 types of scarring in the management of reflux?
To be honest with you, only maybe that's some small category which you can prevent the new scarring. Those girls, you can prevent the new scarring by toilet training, by bowel management, or by sometimes by antibiotic. Otherwise, the dysplastic, you will not be able to do. The boys which have been already having a high-grade reflux and congenital scarring, you cannot help them. Yeah, so just the distinction is for this category of middle, which you can help with to prevent more scarring.
Can I just
do you
put in a
think,
word
Dr.
now, Doctor?
Yeah, sure.
Can I just make a, okay, you're finished, Doctor?
Yeah, go ahead.
Yeah.
Yeah, please.
Yes.
Yeah, I would like to just make to Dr. Martin, this question comes when we are doing adolescent practice. Now, I get some of these patients, especially women, you know, who already have reflux in adult life. They are asymptomatic. They have not had any infection at date. Maybe they had 1 or 2 past normal, like women get up to 3 episodes of infection in a woman per year. We take it as normal. They have reflux. Now, what do you tell these adolescent kids or these girls? Because our biggest worry is not now, is when they become pregnant. When they become pregnant, there might be a huge chance of infection. At that time, we will not be able to handle them. So how would you manage the adolescents having persistent reflux, whether it's after already deflux surgery has been done, not done, detected, that is immaterial. A young girl, adolescent coming to you with reflux, probably 1 episode of UTI has that got, nothing very significant. How would you go about managing this patient? Or what would you advise to this patient?
So I think at least in North America, you differentiate in Europe between childhood infections and adolescence. So as young girls become sexually active, they will have infections, and they're usually cystitis.
Correct.
And they have nothing really to do with reflux. It may, though, be that they have, I don't know the numbers, but they may have more pyelonephritis associated with that. That could be. So the issue is then prevention of infections by education. You can drink right after intercourse. You can have 1 dose of trimethoprim or whatever. There's several possibilities to prevent those infections. And then that takes care of the infection per se, hopefully. And we also learn now only who are people who are prone to infections versus others with the same anatomy. There's probably some innate immunity that plays a role in the urinary tract. But that we don't know or don't understand well enough to make that into a treatment. So again, I don't think that usually a mild to moderate reflux in a sexually active woman plays a big role in the infection. I think it's the mechanics that leads to the infection, and that can be prevented or at least mitigated. How would you go about now the patient has transitioned to the adult service?
No, that's the biggest question I don't, like a classical example is the lady asked me now, she hears me out. I give her all these theories, what we have. Then she asked me, okay, I'm going to get married and become pregnant. We are thinking of a family, or she's already married. Now, what do you do? Can I take a chance of her getting pregnant without doing a deflux surgery? Or do I, that's the question that comes. Should I do a reflux surgery or leave her alone?
So I'll let Dr. Diari answer in a moment because he wants to answer. I think if you differentiate between infection without pregnancy and then problems due to infection during pregnancy. So I always tell them, have a glass of water, bottle of water next to your bed and immediately drink. So that is one thing, but that doesn't help in pregnancy. I don't know, I haven't really reflected enough to see whether the reflux plays any role there or whether it is just some women tend to have these infections. So, but somebody may have read statistics and can tell more about this.
No, I have not read. I have not read anywhere any such studies. And the problem is that if the infection occurs, a severe pyelonephritic infection occurs during pregnancy, then the gynecologist is going to breathe up your neck that I sent you a reference and look, now I can't handle the pyelonephritis. And if it's in the first trimester, that's even worse because we can't give so many antibiotics. That's the most dangerous time. We can't give anything. We can't give for the fever also other than paracetamol.
But then you also have to ask, would they have infections after deflux procedure or after reimplantation? And that, I haven't read about this. I don't know whether somebody studied that.
I just thought even I have not read. That's a big query we have. And that's the biggest question.
20%, almost up 15 to 20% of those who have reimplantation and injection, they get UTI after the surgery. 15 to 20%.
Okay.
So no need to do any surgery.
So
bringing the talk back to children, can we know about deflux surgery, like deflux injections? Can they be used in higher grades? Why are they only till grade, lower grades of VUR that they are successful? What are the fundamentals behind that? So maybe Dr. Hilal can answer this.
Yes, as I mentioned, the success of deflux is higher, and the lower the grade of VUR, the better the success. And previously, when actually initially wasn't deflux, but different material was used, was kind of wasn't used for grade 5 reflux. And but not recently, maybe in the last 10-15 years, actually the people who started the submucosal injection, they started using submucosal deflux injection on the higher grade reflux, especially from Dublin, from the Professor Prem Puri, who I remember he published a publication on specifically on using deflux on grade 5 VUR. There's a lot of technical issue about it, how surgical technical issue, how you inject it. You inject 1 injection, 2 injections within the ureter or just at the orifice. But he, in his paper, in his review, showed that even in grade 5 VUR, deflux is beneficial. I personally agree with him, because even if it's not 100%, even if it's not 90% beneficial, let it be 50% beneficial or 40% beneficial. At least we save 50% of the patients a major reimplantation surgery. And that's why I mentioned that deflux injection is the first line of treatment for me, even in grade 5. But for grade 5, I always tell the parents, the chances of success is not as high. There's a chance it's not going to work. There's a chance that you might need surgery. But as I said, if it works in half the patients, that's very satisfactory for me.
Right. So having decided the management, how do we follow up these children? What is the protocol for following up these VUR cases? I think Dr. Diyari, can you enlighten us?
Dr. Hilal, he present all this one, so you are asking.
I'm just,
usually after,
I would like to highlight certain things.
You mean after the deflux injection, or?
Yes, you have done you've decided, okay, this is either going for medical management,
to be honest
surgical
with
management.
You, sometimes in grade hormone, they are doing after the deflux injection, immediately in the same setting, they will do intraoperative MCUG to see if there is reflux remaining or not. But this is not our protocol.
Practice.
Our practice, yes. We are usually doing it if needed after 3 to 6 months. If the patient sometimes Dr. Hilal knows very well that when you are injecting, sometimes you know that you are successful in this injection. Sometimes the position of the ureter and the opening and the size makes you feeling that you are not confident that you did the injection nicely because some technical. In these, you might repeat it after 3 to 6 months to see if there is still persistent of reflux or not. Or you will just follow by if the patient develop any symptomatic UTI, then you might repeat it again. But as just Dr. Martin mentioned, nowadays, the trend is not to go for surgery or even for injection, because they found that after that, the urinary tract infection is still there in 15 to 20%. And with time, there might be spontaneous regression or downgrading of the reflux. So sometimes it will disappear by itself, or sometimes it will be downgraded.
Well, this is getting a little confusing, if I may say so. We are not sure whether we should give prophylactic antibiotics about their role. We are not sure whether we should operate. What treatment are we going to offer to these children, and what are we going to tell the parents?
Can I
Yes.
mention something, please?
Sure.
About there's a lot of work, discussion, studies about failure of surgical treatment for VUR. And what Dr. Diari correctly mentioned, that many patients, after deflux injection, they continue to have VUR or continue to have urinary tract infection. And as I mentioned in my talk, a major contributory factor for the failure of surgery in VUR is bladder bowel dysfunction. And that's what the American Urology Society has stressed for that. Actually, I do treat some patients who I inject for deflux, and I find either they still have some reflux or they still have UTI, and I do ultrasound scan. If I find they have high residual or thick walled bladder, I start them on Ditropan, and I start them for treatment for BBD, because it's been shown that BBD is a major contributory factor for failure of surgical treatment for VUR.
Dr. Hilal, I'm very happy to say that, because that is exactly the point. So we're not focusing on the fact, is there reflux or not? We're looking at the whole patient and the whole environment. And I think one other factor, the ReImplantation study has shown you have to treat 16 to 22 patients in order to prevent one infection. So it's quite not that effective. And finally, most of these studies have excluded or did not find enough patients who had very high reflux, grade reflux. So grade 4 and 5 are very underrepresented. And these are the ones that are really the problem. So I think we're coming to a concept where we look at all the factors that contribute and try to mitigate. And then the problem of the infections and of the reflux itself will become less important per se. I remember when I had my first nephrology position, we subjected the children every year to VCOG. Horrendous. I would not do that anymore.
That's why I brought up the issue of follow-up, actually, not only after deflux, but in general. It's not
the number of infections and whether you prevent constipation and whether you have good hygiene for the voiding, good voiding habits, double voiding, and all these things is much more important than antibiotics or surgery in many patients. Not in all, but in many.
Sure.
And
now moving on to
we don't understand the really the pathophysiology of vesicular reflex in a proper way. Until now, we don't know why males, they are having more high-grade reflux and more severe reflux than a female. So there might be still some genetics, which we don't know, as Dr. Hilal mentioned initially. There is some genetic predisposition for this high reflex in male gender.
But they also have many more Kakut, and they're the ones who have tripled the number of transplant and end-stage disease because of the congenital anomaly. So most of the patients who have this high-grade reflux also have bad kidneys to get going.
Yes, sure.
So moving on to the second scenario of circumcision. Simple question, a parent asks us, what is the advantage of this? Should we do it? Should we not do it? So I would like each of the panelists to opine on this. What is their opinion?
Well,
what are the advantages?
Well, as you know, most circumcision done in this part of the world is for ritual circumcision. And the rest of the world, actually in the United States, maybe 60% of male are circumcised. Often I get parents that comes to my clinic who are not Muslim or Jews. They just ask, do you recommend to do circumcision? And I explain to them, actually, if you open the AAP, American Academy of Pediatrics, and do a search on circumcision, you will find the AAP recommendation for circumcision. The first recommendation was in 1999. This was reviewed in 2012. And the latest recommendation is that for neonatal circumcision, there's a distinct health benefit, but they stress for neonatal circumcision. The health benefit is, as most of you know, it reduces greatly, almost abolishes the incidence of penile cancer. It prevents cervical cancer in partner of circumcised male. It reduces the incidence of UTI. It reduces the incidence of sexually transmitted disease, including HIV, and it reduces the incidence of balanitis. And of course, when there's no foreskin, there will be no phimosis or paraphimosis. But the American Academy of Pediatrics stress the benefit, the health benefit of circumcisions to neonatal circumcision. Why? Because the health benefit is statistically marginal. The advantage is there, but it's small. If you want to do circumcision at an older age group, which need to be done under general anesthesia, then you are introducing the risk of general anesthesia. Then that advantage, that health advantage, will almost disappear. Therefore, when parent comes to me to ask about, is there any health benefit to circumcision, I explain to them all the health benefit for the circumcision, but I stress to them, if you need to do it, you need to do it at the neonatal age, before 3 months of age, under local anesthesia, to avoid general anesthesia. If you're going to subject the child later for general anesthesia for circumcision, that mitigate all the benefits of circumcision.
Just a small question to Dr. Hilal. You mentioned that there can be bleeding, which can be very significant. In fact, of a case where the baby passed away. So now this circumcision is done by a variety of professionals in different settings, clinical settings. Any preoperative minimum workup is done for bleeding or no? Or should be done or no?
Well, of course, any history of familiar or bleeding diastasis, that's a contraindication for circumcision. Is a family, that's obvious. But without any bleeding or coagulation disorder, bleeding do happen. And as I said, the vast majority of bleeding, we see a lot of bleeding, are minor, self-limiting, doesn't need anything done. If when the patient come back with bleeding, the only way is to convert to remove the ring and to stitch it. But most important thing to avoid disasters like cases that happens with the mortality and cases that happen with severe bleeding that needs admission and transfusion is only patient education. And as I said, we tell the parents, check the nappy regularly at night after circumcision. If any blobs of blood bigger than dirham size, you bring it to ER.
Yeah, that makes sense. Bleeding, I mean, if the circumcision is done and the child is observed for bleeding after the circumcision, the bleeding at home is not really that common. I mean, it's uncommon. And rare. I could say rare, but we still instruct parents to watch for it. In 43 years, I've done thousands of neonatal circumcisions. I had two came back with bleeding, who needed their circumcision to be revived. One of them actually did not have vitamin K. I knew, retrospectively, I took the history and the parents said he did not have vitamin K at birth. And the other one, he bled from his frenulum, from the penile frenulum. And those are the only two that had significant bleeding that needed revision.
But doctor, you are a qualified, trained pediatric surgeon. this is being done by various specialities. I don't think with
I know
adequate expertise in the area. So considering the fact that this is one of the most common operations being done, I think it's something to think about. Anyway, moving on to the third case scenario of renal calculi. Incidence of renal calculi is increasing world over. What is the reason? Why is it increasing? We are also seeing more cases in our practices. So, Dr. Debashish, what is the cause for this? What has been the theory?
Yeah, basically, this incidence of increase, which is being seen world over, especially there have been multicentric trials done in United States. And even in the stone belts area, papers coming out from Turkey and Pakistan are showing an increased incidence of stone formation. Now, one of the reasons we think is could be that increase in obesity. Obesity plays has a very big correlation with stone formation. The higher a BMI, the higher the incidence of forming stones. Secondly, there is increased intake of this in children about these beverages, which are these cold drinks and all these things, what we call this Pepsi, Coke. Now, these increased incidence of beverages increase the oxalate content in your body. They're filled with oxalate, these preservatives added in these cold drinks. And that could be the other increase of stone formation.
Right.
Then there is also environmental factors that the climate is causing increase in temperatures around the world. And people living in dry, arid areas, there is increased incidence stone formation. And of course, other thing could be that the increased use of CT scan, which we're using. As I already mentioned in this thing, the diagnostic modalities have improved so much that even small stones can be caught. If you see that the increase in stones, there is a shifting pattern. Initially, in children, we used to get bladder stones a lot. In all papers, used to say the commonest incidence of stones in children are bladder stones. Now we are getting more and more ureteric stones. Probably this is because any abdominal pain comes to a pediatrician anywhere in the hospital around the world, we are more inclined to do CT scan rather than previously. And CT scan detects even the smallest stones. So I feel these are some of the conditions which is causing an increased incidence. May not be a true incidence, maybe also be that we're detecting them with higher accuracy.
Excuse me, Dr. Debashish, if you use a transducer, I mean 7.5, even 3 millimeters, I think they can pick up.
On ultrasound, it's not the transducer problem, sir. It is basically ureteric stones. There is too much gas in the abdomen. And the ureter, unless it's dilated, to see something on ultrasound, we require a good acoustic window. That is why whenever we do the KUB, we ask the bladder to fill the bladder up. Now, when the bladder is full, we get a good acoustic window to see stones in the lower third, especially uretrovesical junction. Not truly lower third, near the uretrovesical junction stone. But in the lower third ureter, it is very, very difficult to catch an ultrasound. It's nearly impossible to catch an ultrasound. It's the lucky urologist, the radiologist who catches a stone. What we see is just the hydroureteronephrosis. So the patient on ultrasound shows hydroureteronephrosis and he has classical renal colic on the ipsilateral side. Obviously, it is a stone. But the yield rate for ureteric stones of ultrasound is not very good. We have to do a CT scan. Unfortunately, that's the present day situation. Whatever transducer use, or whatever the expertise of the radiologist, it is no question on the expertise of the radiologist. It is just a physical difficulty with the ultrasound modality to correct ureteric stones, not kidney stones. Kidney stones are well caught by ultrasound. I wonder if have any other such thing, why ultrasound does not catch the ureteric stones. If my colleagues can tell any other reason. I know of no other reason why ultrasound does not catch ureteric stones. Dr. Diari, Dr. Hilal, any idea about why we have to use CT scan so much?
Probably ureteric stones are very close to the spinal cord. And with ultrasound, it's not easy to pick it up.
Into the process, spinal process. Sometimes
Actually,
it's
we are
diagnosed
using
by
CT
non-surgical.
scan very rarely.
Oh, really?
Yeah. I don't know whether we miss stones, but as you already pointed out, the symptomatic is different, and we may not be so focused on the typical presentation. So if there's abdominal pain or so forth, and there's no stone, so we are satisfied with that. But we look more at metabolic causes that, such as hypercalciuria or something, that does not yet form or lead to proper stones, but to symptoms. So
Yes, sir.
I don't know. I don't know whether we miss them, but a good ultrasound, with some exceptions, can catch them. We can repeat the ultrasound if we feel we miss them, and maybe then the conditions are better, better filling of the bladder, better less gas in the abdomen, in the bowel, and so forth.
Yeah, as one small question, sorry to Dr. Devashish. Nowadays, people, children especially, taking lot of ketchup, tomato ketchup, and we know this, they have citrate. Does it have any role in stone formation?
Could be, because tomatoes is one of the things we do not. Tomatoes have high oxalate contents, and definitely a lithogenic diet is high in tomatoes. So probably, as you said, this fast food culture, along with the beverages that they're taking, children are taking more and more, could be contributing to more stone formation. Maybe.
In that context, it's the question of solubility. So if you eat more sodium salt, you have less solubility. And I just read that the increase of sodium salt has gone from 200 milligram per day to 3,000 milligram per day in the young population.
Perfect.
So there is probably one other contributor that is very important.
And as you noticed in my listing, what I've said, hypernatriuria is one of the commonest metabolic abnormalities in stone formation. And that's again, our fast food culture is making children eat more salt. And this is one of the things we always miss. We tell them, reduce your oxalate, reduce this, reduce that, but we forget to tell children to reduce their salt intake, especially adolescents. I forget. Actually, I also forget.
And sometimes I just measure the sodium excretion in the urine, do a fractional excretion, and see how much comes there. And you'll be surprised, huge amount. Even if they say, oh no, we don't eat salt. The salt is in the processed food.
So, Dr. Martin, what would be the basic metabolic workup that you would do in these cases in order not to miss some important underlying causes?
Right. And to reiterate what Dr. Deshebesh said before, so if we look at the frequencies, probably hypocitraturia, hypercalciuria are the front runners. And then we have hyperuricuria. And we have here in this area also a certain amount of frequency of hyperoxaluria. And then we have cystinuria. So these are probably the main culprits. And I see a young child with a stone, I look at those factors. And it's relatively simple. Then the next question is being asked, do we need 24-hour collection? And I say no, because it's probably very inaccurate and very inconvenient. And we have now nice tables of normal or reference values for creatinine ratios. And that is probably good enough. And if you do that 2 or 3 times, the spot urines, ideally in the morning, but it doesn't really matter that much, then we should be able to pick up any of those conditions that are amenable to management or to treatment.
Right. And what about the genetic analysis in these children? So
I think genetics is becoming cheaper and cheaper, but still it's a bit not the standard for many insurances. We would not pay for that. So I would go first for the metabolic workup. And then if I have hypercalciuria and I see there's hypercalcemia, there's hypomagnesemia, there's some of these factors, then we can suspect some diseases that are genetically determined, particularly tubulopathies. And then it's worthwhile to do either panel or whole exome sequencing and figure that out. Just remember, the cost of whole exome sequencing today is probably, at least in Al Jalila, about 5,000 dirham. It's less than a day in the hospital or in the ICU. So it's really not anymore that much. But we should have an educated guess. We should not just say, okay, let's do a genetic study. Then the yield is probably very low. We have to have educated assumption there.
Dr. Martin, I would like to interrupt here. I would like to learn from you actually. In my practice, this is a very good forum. I want to tell me practically, what is the basic metabolic test I should do for children or adolescents or even adults? What is the basic metabolic test you require?
Excellent.
Now, up till now, I used to do 24 hours urine. I just wanted to put in context. And it's the most inconvenient test to do. Absolutely, totally inconvenient test. Doesn't work out practically. I don't know how you do it in children, but even in adults, it's a horrible thing. Now, you just mentioned, which caught my attention, that you have nomograms for spot urine sample. Now,
yes.
With reference to that, can you tell us the basic test and can you share the nomograms for the basic test?
Absolutely.
Practical test. You understand what I would just subscribe practically?
Yes. So on the one hand, you can get a sample and ask for calcium, creatinine, uric acid, cysteine, citrate, oxalate. So this would be the
oxalate. All spot samples.
One spot sample. And if you have stones, you will do it 2 or 3 times if the first sample is negative, because there are diurnal variations and you may not catch it. The nomograms, I pulled it out. There is a recent publication. Actually,
now, is this all nomograms based on creatinine ratio, creatinine calcium ratio, creatinine uric acid ratio?
Exactly.
Yes.
So
Wonderful.
if you jot that down, MARA, M-A-R-R-A, first name Giuseppini, in Journal of Nephrology 2019. So MARA, he has beautiful tables.
That is Tomari, I think.
And this is with milligram per milligram and with millimole per millimole. So you have both. And there are additional tables. I had to pull them out from the literature, but where you have the 5 to 95%, 9 to 95 percentiles. So that's even better than just numbers. But this is good enough, and they cite the things. So if
just
you do
one more question along with this, sorry, I'm just saying just one question. These tables are valid if the patient has a stone in place, or has it to be done after we have cleared the stone out?
I think that's
because if there is a ureteric stone or a kidney stone, it is going to leak out a lot of crystals and uric acid. Supposing uric acid stone, then I don't think that's my opinion. I don't think these values would be really valid. So I just want to know, what are these values?
Maybe it's better. I don't know the answer, but if you leak solutes and you catch them, then you know at least this is probably coming from that stone and there's a connection. So I would not care whether the stone is still there or not, okay, as long as you get a sample or two. So that helps. But I had a baby a while ago who produced a number of stones. I did everything. I couldn't find any suspect. We did whole exome sequencing, nothing. And there I had to give up. The patient then moved to the United States. I haven't heard from them, so I don't know what came out of it. So the yield is not absolute, but at least in pediatrics, the younger they are, statistically, you have more success than in adults. And the other thing there is, yes, just for a comment to the 24-hour, so they say 60 to 70% are inaccurate. So just confirming your point that this is almost useless. But it's a good economic factor because there are companies who offer the test and then they get a lot of money for it.
Which changed, may I ask one question? Sorry, because Dr. Debashir reminded me of, there is one Moynihan aphorism. This was for gallbladder stone, that presence of a stone is a tombstone erected to the memory of a dead bacteria. Is there anything in the, urinary system that if a stone is there, was there a bacteria present that this stone is for?
Yeah, there are.
Yeah. In adults, actually, it is bacteria is present. More infectious stones is the commonest type of stones we see. But in pediatrics, definitely it is the other way around. Infective stones are very rarely seen in pediatric population. But in adults, you're right.
not so rare. I guess
Oh, wonderful. I didn't know that.
something. So we do have staghorn calculi. We have proteus in colonizing stones and vice versa. So I always ask, what is the chicken and what the egg in that context? Could be a stone that has bacteria on it or vice versa. But you have probably both. And if you have an obstruction, so UPJ obstruction, then you probably have even a higher risk of stone formation and of infection of the formed stone. So it's not absolutely rare, absolutely not.
So Dr. Saurabh's question is answered that it is a tomb of a dead bacteria which we are breaking apart.
There's a question regarding stone analysis. So we have, you've treated it and you have now a stone in hand. Is it done in each and every case? What is the importance of it? Should it be done?
I didn't catch the question.
The stone analysis after treatment.
Oh,
do we analyze the stone itself?
If you have a lab that does it, it's great. But I still have to find a lab here who does it reliably. Our lab doesn't do it.
Right. So, is there anything else related to stones, or Dr. Ayman?
Related to design.
I think there is some disturbance.
Maybe I can interject briefly. So we have also to look at the other way around, not only what is in the urine that causes stones, but what are diseases that are associated with stones. So I'm looking at distal renal tubular acidosis with calcium formation, nephrocalcinosis or stones. Cystinuria, have we mentioned already. Phosphoribosyl transferase deficiencies. There are primary hyperoxaluria, we mentioned already. So and then there's combination of hypomagnesemia, hypercalcemia with nephrocalcinosis. There's a number of genetic diseases and dense disease that can be actually guessed or diagnosed because there's a stone and vice versa. If they have these diseases, we can monitor for the development of stones.
I ask one question for changing it. Sorry. We have different positions for passing a urine, squatting, sitting, standing. Which is good for urinary system and which is harmful? This was a question I was asked once.
Squatting is the best, it's very clear.
No, because this was, I was reading during my MBBS in Hamilton Belly and Love.
Squatting is the best.
Too much squatting may cause bending of, the passage. Just experts are there because this question I was asked once also.
I don't think
toilet is definitely not the best physiologically, but I don't want to comment on this further.
No, I think Dr. Ayman, did you want to ask something?
Yes.
Yeah.
Our colleague
your voice is interrupted, Dr. Ayman. We cannot hear you. Your voice is interrupting.
Okay, so the next question is regarding testicular torsion. Doctor's asking whether cremasteric reflex can be used, has any value in differentiating testicular torsion from epidermolysis. So, Dr. Debashish.
No, in acute testes, in any acute condition of the testes, the cremasteric reflex is no more active. Instead of that, what you can differentiate between the two is the French sign. When the child is lying in severe pain, or any adult with the testicular torsion, the pain is so severe, I don't think any cremasteric reflex is coming into picture, anything there. It's just a huge swollen, not a huge, a real tender swollen thing there. So nobody can check a cremasteric reflex even if it's present. What we check is the French sign. If you lift the testes up and the reduction of pain is there, then definitely, mostly, not you can't say definite in anything, mostly it is epidermolysis. And that is what we use instead of cremasteric reflex.
So another thing is, irrespective of the number of hours that may have elapsed since the beginning of the symptoms, you would still, if you're thinking of torsion, you would still go and operate. And
Oh,
the
yes.
decision to preserve the testes, I mean, is there any change on that? What is decided?
No, this is, yeah, if it
How
is
is it done?
torsion, you have to operate. You cannot leave a dead testis behind. There is a high risk of infection and abscess formation. So torsion testes, you have to operate, irrespective of how many hours the child is presented. After you explore and you have detorsed it, now you wait. You put hot mops on it and you see if the vascularity is returning back or not. Many things have been tried. In fact, not only this injection of papaverine and hot mops, some people also take to incise the tunica, thinking like it's a compression syndrome because there is edema and congestion of the testes. So if you incise the testes, you release the pressures and maybe the vascularity will return. But after doing all these and you wait a significant amount of time. In fact, I don't know about the pediatric surgeons, when we do torsion testes, it's not a very big procedure. You go down quickly, twist the testes around. The procedure itself is short, but the long hours is how long we wait. We give all the time in the world possible for the vascular to return. If after doing all your measures and after a sufficient interval of time, if the vascularity has not returning and it is still black in color, then we go ahead and do an orchidectomy. That is it. That is
I
the whole
don't know
thing.
now if there is any update for the adult, but for pediatric, it's still controversy because it has been found after 36 hours of a torsion testis, still there is a Sertoli cell which is functioning. So for us, as you just mentioned, the worst scenario is formation of abscess. This is the worst scenario. But we know that this is avascular necrosis and it is sterile. So there is chance of regaining. As you mentioned, we cannot wait for how long we will wait. So just keeping it, it will not be harmful. So we are keeping it. The worst scenario is abscess, which can be just open a stitch and it will be drained. Or it will go for atrophy, as you mentioned, it will go for atrophy. And this has been explained to the parents. So for us, we are not removing a testis because of that. After 36 hours, there are studies which shows that still there is Sertoli cell which are viable. The other issue, which might be after 12 years, 14 years, you are afraid of the antibodies to the other testes.
Absolutely.
In pediatric or below 12 years, this has not been still till now identified. And they are saying that it is still impermeable, the testis, to have been affected by that antibody. So we are in pediatric age group still, we are keeping it, keeping in mind the worst scenario, abscess formation.
I fully agree with you. It is absolutely what is recommended in our urology also, that in pediatric, you make as much effort as you try to preserve the testes. And as I already mentioned in the literature says that children have a very good regenerative power. So I also second that and I fully agree to that. That takes place in adults also.
I also, can I just mention something? I totally agree with Dr. Diari. 10, 15 years ago, we used to explore torsion testis. If it's black, it doesn't get better with warm pads, we used to remove it. In the past 10 years, maybe, we rarely, if ever, do orchidectomy. We never do orchidectomy. Before, actually, we used to do orchidectomy because there used to be some idea about the antibodies. And this has been proven to be totally wrong. So nowadays, no matter what the testis is, we put it back. And as Dr. Diari said, the worst that can happen is to form an abscess, which can be, we give them all antibiotics. If it's formed an abscess, the worst that can happen might need drainage. So rarely, if ever, we do an orchidectomy for torsion testis nowadays.
As regards hypospadias, what is the recommended time when it should be operated, Dr. Hilal?
Hypospadias, I tell the parents when they come with hypospadias, I tell them when the child is, is still infant, small child, preschool age, hypospadias surgery If it's minor hypospadias, it's purely cosmetic issue. It doesn't affect their health. So I tell the parent, this is not a health issue. It's purely cosmetic issue for the future. So the child, when he passes urine, the urine stream will be straight, and also to look normal psychologically, socially. So it's a psychological, social reason for treating minor hypospadias. Major hypospadias, when there's severe cordy, of course, there is a functional issue, but still the functional issue is not in the infancy, it's later on in future life. So I explained to the parents, we get patients with hypospadias from newborn age. So I usually tell the parents would like to operate on them not before 1 year of age, purely to avoid general anesthesia under 1 year of age, because it's been general anesthesia under 1 year of age. It's been shown to be detrimental. And of course, I would like to do the operation before the child go to nursery, definitely before the child is conscious, because surgery on any genital organs, the child should not have any memory of it. So for me, I would recommend surgery between 1 year, after 1 year of age, but probably before 2 years of age. And also depends on the size of the penis. If I see a small baby with hypospadias, I tend to see them just about 1 year of age. I'll assess them. If the penile size is good, then I will operate on them at 1 year of age. If the penile size is still small, I would maybe wait a little bit longer until get some more penile growth. So we'll operate maybe at 1.5 years or even 2 years of age.
Is it the same protocol being followed at Jalila, Dr. Diari?
Exactly. 1 year, 1.5 years before, as Dr. Hilal mentioned, before nursery. Because the other issue is sometimes we have 5 to 10% of complication, dehiscence, infection, fistula, which you need to redo the surgery after 6 months to 1 year. Then at least at that time, then when he will be in school, he will be finished his surgery. It's not only because we want to do it at 1 year, but we are giving also a backup for ourselves. If he needs a second surgery, then we will do before going to school. Exactly.
Can you hear me now?
Yes, doctor. Yes.
Yes. Can I ask a question? When is the right time to operate on a retractile testicle?
We don't operate on retractile testicle. By definition, retractile testicle is the testicle that has a strong cremasteric reflex, and therefore the vascular bundle is not short enough. And by definition, retractile testis is the testis that can come down all the way to the scrotum, remain there, but retract up when you elicit a cremasteric reflex. All retractile testis tend to get better by itself as cremasteric reflex get abolished with age. The only concern about retractile testis when we can intervene is because the testis, if there's strong cremasteric reflex with a strongly retractile testis, and the testis is sitting up high most of the time, I feel that it's subjected to a higher temperature, same as an undescended testis maybe, and therefore probably at age of 4 or 5, I might recommend giving them beta HCG injections, and that will abolish the cremasteric reflex and is very successful in treating retractile testis.
We see some retractile testicles with the hypoplastic scrotum or underdeveloped scrotum, flat scrotum.
Which means that the testis is not in the scrotum.
It's not retractile.
Exactly, but you can bring it down. I mean, you can bring it down, and when you bring it down,
as Dr. Hilal mentioned, that means most of the time it is not in the scrotum. If it was in the scrotum, it will be well-developed scrotum.
So this,
but Dr. Jundi, I will formulate the words. I am not mentioning ectopic, retractile. Any testis for me, any testis not in the scrotum, but by age of 6 months, it should be come down. That's what we are doing. Not retractile, ectopic in the thigh, in the superficial inguinal pouch. No, we feel that if the testis is not fixed in the scrotum by 6 months, then this patient most probably will need surgery. That's what I.
Yeah. The other question is, would you do an ultrasound on a child with a missing testis? You can't find, I mean, the testicle is not there. Would you do an ultrasound?
I personally do. I tell you. Sorry. You mean impalpable testis?
Impalpable or, impalpable testicle.
Actually, the BAPS recommendation, British Association of Pediatric Surgery recommendation, they say there's no role of ultrasound in impalpable testis, and you should go straight for laparoscopy. I personally do an ultrasound, and I do ultrasound specifically, mention the ultrasound. I want to look at the groins, at the inguinal canal, because testis, it's only palpable if it's outside the inguinal canal. If it's under the muscle, most of the time is impalpable. So I would personally do ultrasound, despite the recommendation of BAPS not to do ultrasound and go straight for laparoscopy, because often the ultrasound shows the testis to be in the inguinal canal. And if the testis is in the inguinal canal, then I feel I would go for an inguinal approach, orchidopexy, rather than laparoscopic 2-stage or 1-stage orchidopexy.
Second that.
If there is any suspicion of this is a DSD, then ultrasound is recommended. This is number one. For example, severe hypospadias and impalpable testis.
Sure.
Then I will go for ultrasound as a part of assessment of DSD rather than to see the testis. This is number one. Number two, just 1 month back, I did one of my colleagues requested an ultrasound for a groin for a child which is 85 kg, 85 kilogram. So by all means, it was impossible to palpate any testis, a fat like that, 10 centimeter. So it is impossible. And both testes were in the groin, which saves me from going laparoscopy. So in an obese child, you might still, as Dr. Hilal mentioned, you might go for ultrasound, but not for any other child with impalpable testis. Unilateral, not bilateral. Bilateral, it goes for the DSD and assessment of DSD.
If we go like this, we are going till morning.
No,
But we'll continue till questions.
I think we have come to the last scenario now of neurogenic bladder. So which is a big topic by itself, but we cannot discuss everything. But still, I would like maybe some pointers. Dr. Martin, do you come across these children? Are you handling them, or is Dr. Diari handling them?
Ask in many instances Dr. Diari to help me. But in principle, I don't like the word neurogenic bladder. I like the word neurogenic bladder dysfunction, because it's not neurogenic per se. Yeah. But apart from the semantic, yes, there's some screening that we have to do. We have to look at the tethered cord issue, bone spinal deformity, or meningomyelus. Here, there's a whole slew of things, sacroiliac malformation that we have to rule out. That's number one. And you can even, with history, sometimes elicit that there's motoric developmental delay or abnormality. And then you have all these, I don't know whether we call them secondary forms, where BBD and all what we have discussed plays a role, and then you have woody functioning, which is not purely neurogenic dysfunction. And when I'm at that stage and I'm not clear, then I will definitely ask Dr. Diari or somebody else to help me with this and do urodynamic studies or the tricks that they have on their sleeves.
I think, Dr.
Right.
Kalpana, you kept the last topic, which is the most difficult topic till now, the neurogenic bladder. Yeah, it is really.
It can be a prelude to the next webinar, doctor, no problem.
Yeah, I feel it will need a full webinar, full day on
Yes.
neurogenic bladder
Absolutely.
dysfunction, neurogenic bladder, as just Dr. Zorab mentioned initially. Yes, neurogenic bladder, we have a lot of cases, especially because we have a spina bifida clinic. So in spina bifida clinic, we are seeing a lot of neurogenic bladder dysfunction, and which needs a regular follow-up, regular ultrasound, hydrodynamic, and most of them, they need CIC. Might be things I want to highlight. Please don't treat too much asymptomatic bacteriuria in these people. And not every time you are seeing in the clinic, ask for urine analysis, because most of them will be contaminated, and you are just treating antibiotic, which increase the risk of resistance. The other parts of urodynamic study and these things, I feel needs really a full webinar. But ultrasound regularly needed to see the upper system, because all our work on the neurogenic bladder is to save the upper system, the kidneys.
Thank you.
Now it is 12:15. In India is 2 o'clock in the morning. Still we are having 400 people are following us at this time. I think we'll have another webinar.
Yes.
Dr. Diari mentioned. Now, one thing I said, in the more than 40 years back, we used to read the bladder chapter, the urinary bladder. The Hamilton Bailey said, a urosurgeon always finished his prayer by saying, "Oh God, when you want to take me, may it not be through the bladder." That this pain of cystitis is so much, he used to pray that, "Oh God, please don't take me from there." Means I don't want to die of the bladder pain. So with this
it's a very famous text in our textbooks. Yes, this is a very famous quotation in all our. It is split up in all the urological societies and all. Wonderful, wonderful way to end it. Yeah, that is a
Thank
truly.
you very much, Dr. Mata, Dr. Debashish, for excellent presentation. Dr. Martin, Dr. Diari for excellent panel discussion. Dr. Kalpana and Dr. Ayman for moderating this session. Really, it's still, 400 people are following us. Discussion is so hot. If it goes like this, as I predicted, till morning it may go. But so I would like to thank Tawfiq and Fadi also. I would like to thank all viewers staying with us. Thank you very much for tolerating us. Dr. Kalpana, final remarks.
Thank you.
No, we had a good time, discussing the pros and cons of the various issues raised today, knowing very well that these are topics which can be dealt with in greater detail. Each one by themselves can be a webinar, but I thank both the speakers, the panelists for their expert opinions, and my co-moderator for helping me out. So thank you, Dr. Sora, for your wonderful introduction as well. I enjoyed that. Thank you.
Thank you very much.
Thank you.
Yeah.
Thank you.
Good night, everyone.
Thank you. Good night.
Night.
Good night. Thank you
Dr.
very much.
Hilal.
Thanks.
Assalamu alaikum, Dr. Hilal.
Ala Diari.
Good night.